Hello students, listen to the lecture on the topic of regulation of the menstrual cycle and menstrual abnormalities. Menstruation or normal periodic uterine bleeding under the influence of pituitary and ovarian hormones. This recurring process is established during puberty and continue until the years prior to menopause. Menarche usually occurs at age between 12 and 14. Regular ovulatory cycles are usually established by the third year after menarche and continue until the perimenopause. Therefore, between 15 and 45 years of age, a woman has approximately 30 years of ovulatory reproductive cycles. Its termination is an menopause and normally occur between 49 and 50. However, medical, some disease, radiation, or surgical intervention may cause artificial menopause at an early ages. Normally, menstruation is regular and painless. The reproductive cycle may be interrupted by conditions including pregnancy, lactation, illness, gynecological disorders, endocrine disorders, some exogenous factors such as hormone-based contraceptives, and various other medications. The first day of menstrual bleeding is considered day 1 of the menstrual cycle. Normal menstruation lasts 3 to 7 days, during which women lose approximately 50 to 90 milliliters of blood. The duration of an adult menstrual cycle from the beginning of one menses to the beginning of the next menses averages approximately 28 days, with a range of 21 to 35 days. Uterus consists of 3 villi: apillae, serosa, middle villi, myometrium, and inner villi, endometrium. The uterine cavity is aligned with endometrium, which is composed of an overlying epithelium, invaginating glands, and a supportive vascular stroma. This layer is divided into functional layer, which is locked with menses, and basalis layer, which is served to regenerate the functional layer following each menses. Hypothalamus, pituitary, ovarian axis refers to the complex interactions between the hypothalamus, pituitary, and ovaries that regulate the reproductive cycle. Those interactions are based on the interplay of the hormones released by those structures: gonadotropin-releasing hormone, the gonadotropins, follicle-stimulating hormone or FSH, and LH, and the ovarian sex steroid hormones, estrogen and progesterone. Menstrual cycle comprises 3 distinct phases. The follicular phase begins with onset of menses and ends on the day of luteinizing hormone surge. Ovulation occurs within 30 to 36 hours of LH surge. The luteal phase begins on the day of LH surge and ends with the onset of menses. The follicular and luteal phases each last approximately 14 days in reproductive age women. The gonadotropin-releasing hormone is secreted in pulsatile fashion from the arcuate nucleus of the hypothalamus. gonadotropin-releasing hormones reach the anterior pituitary through the hypothalamic pituitary portal vascular system. The pulsatile secretion of gonadotropin-releasing hormone stimulates and modulates pituitary gonadotropin secretion. The pituitary gonadotropins, FSH and LH, are glycoprotein hormones secreted by the anterior pituitary gland. FSH and LH are also secreted in pulsatile fashion in response to the pulsatile release of gonadotropin-releasing hormone. The rate of secretion of FSH and LH are determined largely by the level of ovarian steroid hormones, estrogen and progesterone, and as ovarian factors. At birth, the human ovary contains approximately 1 to 2 million primordial follicles. A large number of those inactive primordial follicles undergo a degenerative process known as atresia during childhood. Close to menarche, only 300,000 to 500,000 oocytes remain. The immature oocyte is encircled by a single layer of granulosa cells, followed by a thin basement membrane that separates the follicle from the surrounding ovarian stroma. Granulosa cells produce estrogens, including estrone and estradiol. During follicular development, FSH binds to FSH receptors on the granulosa cell, causing cellular proliferation and increasing binding of FSH and hence increased production of estradiol. Estradiol stimulates the proliferation of LH receptors on theca and granulosa cells, and LH stimulates the theca cells to produce androgens. Greater androgen production leads to increased estradiol production. Rising estrogen levels influence the pituitary gland through negative feedback and result in suppression of FSH and LH secretion. In the late follicular phase, peak estradiol concentration from the dominant follicle have positive feedback on the pituitary, which stimulates the mid-cycle surge of LH secretion that is necessary for ovulation. On the 8th and 9th day of the cycle, the estrogen level stops rising and LH and FSH levels begin to fluctuate. With ovulation, the dominant ovarian follicle releases its oocyte and transition to a progesterone-secreting ovarian cyst, the corpus luteum. The production of progesterone begins approximately 24 hours before ovulation and rises rapidly thereafter. Maximal progesterone production occurs 3 to 4 days after ovulation. The lifespan of the corpus luteum ends approximately 9 to 11 days after ovulation. On this image, you may see ultrasound visualization of ovarium. Just right in the middle, you may see major dominant follicle. On this image, you may see uterus, just right in the middle, and the endometrium, which lengths depend on the day of the menstrual cycle. For example, just right in the middle of menstrual cycle, the normal length of endometrium should be approximately 1 centimeter. If conception doesn't occur, the corpus luteum undergoes involution, and progesterone production sharply declines. This withdrawal of progesterone releases FSH from negative feedback. Those FSH levels begin to rise prior to menstruation and the initiation of new cycle. The corpus luteum measures approximately 2.5 centimeters in diameter, has a characteristic deep yellow color. After a few months, the corpus luteum becomes a white fibrous streak within the ovary, called the corpus albicans. At the end of the luteal phase, serum concentration of estradiol, progesterone, and LH reach their lowest levels. In response to low hormone levels, FSH begins to rise in the late luteal phase before onset of the menstruation. The endometrium undergoes histological changes during the menstrual cycle. During menstruation, the endometrium is expelled and only the basal layer remains. During the follicular phase, the rise in estrogen levels stimulates endometrium cell growth. The endometrial stroma thickness and the endometrial glands become elongate to form the proliferative endometrium. Each cycle generally passes through 4 phases: the menstrual phase, the proliferative phase, the ovulatory phase, and secretory phase. On this image, you may see the changes in ovarian follicles and in the uterine endometrium. Menstrual phase or menstruation refers to the shedding of the superficial layers of the endometrium with subsequent repair in preparation for regrowth from the basalis layer. Menstruation is initiated by a fall in circulating concentration of progesterone. After a menstrual period of 3 to 7 days, bleeding gradually diminishes. An interval between ovulation and menstruation normally is almost exactly 14 days. On this image, you may see endometrial stroma, which consists from functional and basal layer. New proliferative endometrium grows rapidly under the influence of estradiol, in synchrony with the growth and maturation of the oocyte and its follicle. A key element in growth of healthy endometrium is formation of new blood vessels, which seems to occur by elongation and expansion from pre-existing small vessels in the basalis. The proliferative phase consists of early phase, the middle proliferative phase, and late proliferative phase. On this image, you may see synchronized ovarian cycle and uterine cycle. You may see the changes in endometrium depending on the day of the menstrual cycle. During ovulation, the oocyte is expelled from the follicle, and the follicle is converted into the corpus luteum. The ovulatory phase occurs with ovulation on about the 14th day of 28-day cycle. The secretory phase technically begins with ovulation. The development of healthy secretory endometrium is essential for implantation and successful development of pregnancy. A menstrual cycle plays basic role in realizing future reproductive function. Thus why some menstrual abnormalities may lead problems with reproductive function. Now, let's talk about menstrual abnormalities. The length of the menstrual cycle varies from woman to woman. The normal duration of the menstrual cycle is from 22 to 35 days. Oligomenorrhea is defined as menstruation occurring at an interval more than 35 days. Polymenorrhea is defined as menstruation occurring at an interval less than 22 days. The normal duration of menstruation is from 3 to 7 days. The hypomenorrhea is the duration of menstruation less than 3 days. Hypomenorrhea is the duration of menstruation more than 7 days. Amenorrhea is diagnosed in a female who has not menstruation during 6 months. Amenorrhea is the absence of menstruation during 6 months or longer, one of the most common reasons of gynecological disorders. On this image, you see classification of amenorrhea. We generally divide amenorrhea to two groups, physiological and pathological. Physiological amenorrhea is the cessation of menstruation for completely normal reason. For example, in girls before sexual maturation, or the lack of menstruation during pregnancy and breastfeeding, or in women during postmenopausal period. Imperforate hymen and transverse vaginal septum are common reasons of false pathological amenorrhea. The clinical symptom of imperforate hymen is encyclical abdominal pain. The pain is due to dysmenorrhea associated with the accumulation of menstrual blood within the vagina. This situation is known as a hematocolpos. It is very unusual for much blood to accumulate with the uterus, as the uterus is the muscular organ which is difficult to distend. Girls with vagina septum also has cyclical abdominal pain due to the development of hematocolpos. But the thickness of the transverse vaginal septum means that the clinical appearance is very different from that of an imperforate hymen. Abdominal mass may be palpable, but inspection of the vagina shows that is blind ending, and also it may be bulging. It is pink, not blue. Transverse vaginal septum may occur at 3 levels, known as a lower, middle, or upper third septum. Hymen or vaginal atrophy, usually corrected by surgery. It's an hymenectomy and after blood aspiration. For the majority of pubertal girls, menstruation is the final result of a series of events which result in sexual maturity. Maturation of the hypothalamus through several years of late childhood begins a cascade of events which finally result in the establishment of the normal menstrual cycle and menstruation. Amenorrhea will result when there is a failure of function in any of the organs involved in this cascade. Primary amenorrhea. If a young woman has never menstruated by age 13 without secondary sexual development, or by age 15 with secondary sexual development, she is classified as having primary amenorrhea. This is the reason of primary amenorrhea: hypergonadotropic hypogonadism, gonadal dysgenesis, hypogonadotropic hypogonadism, and congenital adrenogenital syndrome. Hypergonadotropic hypogonadism defined as any process in which ovarian function is decreased or absent, that is, hypogonadism. Due to lack of negative feedback, the gonadotropins LH and FSH have increased levels. This is hypergonadotropic. Gonadal dysgenesis is the most frequent cause of primary amenorrhea. The gonad is described as dysgenetic if it is abnormal in its formation. This encompasses a spectrum of conditions which vary with the degree of differentiation. The commonest is Turner syndrome. The missing chromosome may be either X or Y. There are other circumstances in which the gonadal dysgenesis may be associated with mosaic. Here, two cell lines exist within one individual, the most common being 45X or 46XX. There are other structural chromosomal anomalies associated with gonadal dysgenesis, known as deletion. If the deletion involves the part of the long arm of the X chromosome or the short arm, then loss of this genetic material may affect gonadal development. The higher the percentage of 45X cells, the more likely are the features of Turner syndrome. Turner syndrome. In this condition, there is an abnormality in or absence of one of the X chromosomes in all cell lines. Patients with Turner syndrome have straight gonads with an absence of ovarian follicles. Therefore, gonadal sex hormone production doesn't occur at puberty. Those patients typically have primary amenorrhea, short stature, web neck, shield chest with widely spaced nipples, high arched palate, and an increased carrying angle of the elbow. Testicular feminization syndrome. It's a genetic disorder that makes XY fetuses insensitive to androgens. Phenotypically, normal woman with adequate breast development, normal external genitalia and vagina of variable depths, absent uterus and absent pubic hair and axillary hair. Patients have made karyotype XY. Hypogonadotropic hypogonadism. The term implies that the primary abnormality lies in the hypothalamic pituitary axis. A decrease in gonadotropin stimulation of the ovaries leads to loss of ovarian hormone production. It is also one of the causes of primary amenorrhea. Maybe delayed puberty, when delayed gonadotropin releasing hormone pulse reactivation. It may be a hypothalamic and pituitary dysfunction, where the gonadotropin deficiency due to stress, weight loss, or some chronic disease like tuberculosis. Maybe Kalman syndrome, where inadequate gonadotropin releasing hormone pulse secretion reduced FSH and LH levels, and central nervous system tumors like craniopharyngioma, where we have reduction of gonadotropin releasing hormone secretion and reduction of FSH and LH. On this slide, you see the table of differential diagnosis of primary amenorrhea with normal external genitalia based on breast development and uterine presence or absence. Just like an example, if patient has an absence of breast development but uterus is present, a probable reason for the primary amenorrhea may be gonadal failure or central nervous system like hypothalamic pituitary disorders. Now let's talk about secondary amenorrhea. Cessation of menstruation for 6 consecutive months in a woman who has previously had regular periods is the usual criteria for investigation. However, some authors consider 3 or 4 months amenorrhea to be pathological, but here we enter the gray area between amenorrhea and oligomenorrhea. Women with secondary amenorrhea must have a patent lower genital tract and endometrium that is responsive to ovarian hormone stimulation, and ovaries that have responded to pituitary gonadotropins. Secondary amenorrhea is best classified according to its etiological site of origin and can be subdivided into disorders of the hypothalamic, pituitary, ovarian, uterine axis, and generalized systemic disease. The principal causes of secondary amenorrhea are shown in this slide. On this slide, you see causes of hypothalamic pituitary amenorrhea. It's a functional causes which depend on the weight, which is weight loss or obesity, drug-induced causes, neoplastic causes, psychogenic causes, and other causes which include head injury and chronic medical illness. Psychogenic reason for primary amenorrhea. Studies have failed to demonstrate a link between stressful life events and amenorrhea of greater than 2 months. However, stress may lead to weight loss, which may then cause menstrual disturbance. Another hypothalamic cause of primary amenorrhea is an weight-related amenorrhea. Weight can have profound effects on gonadotropin regulation and release. Weight and eating disorders are also common in women. A regular menstrual cycle will not occur if the body mass index is less than 19. fat appears to be critical to a normally functioning hypothalamic pituitary gonadal axis. It is estimated that at least 22% of body weight should be fat to maintain ovulatory cycles. This level enables the extra-ovarian aromatization of androgens to estrogens and maintains appropriate feedback control of the hypothalamic pituitary ovarian axis. Girls who are significantly underweight prior to puberty may have primary amenorrhea, while those who are significantly underweight after puberty will have secondary amenorrhea. To cause amenorrhea, the loss must be 10 to 15% of the woman's normal weight for height. Weight loss may be due to a number of causes, including self-induced abstinence, starvation, illness, and exercises. Anorexia nervosa is an extreme end of a spectrum of eating disorders, and it's invariably accompanied by menstrual disturbance, and indeed may account for between 15 and 35% of patients with amenorrhea. Weight-related amenorrhea may also have profound long-term effects on bone mineral density. Hyperprolactinemia is the common pituitary cause of amenorrhea. If the prolactin concentration is greater than 1000 miles per liter, then the test should be repeated, and if still elevated, it is necessary to image the pituitary fossa on CT or MRI scan. Hyperprolactinemia may result from a prolactin-secreting pituitary adenoma or from a non-functioning disconnection tumor in the region of the hypothalamus or pituitary, which disrupts the inhibitory influence of dopamine on prolactin secretion. Large non-functioning tumors are usually associated with serum prolactin concentration of less than 3000 miles per liter, while prolactin-secreting macroadenomas usually result in concentration of 8000 miles per liter or more. In women with amenorrhea associated with hyperprolactinemia, the main symptoms are usually those of estrogen deficiency. In contrast, when hyperprolactinemia is associated with polycystic ovarian syndrome, the syndrome is characterized by adequate estrogenization, polycystic ovaries on ultrasound scan, and a withdrawal bleed in response to a progesterone challenge test. Galactorrhea may be found in up to a third of hyperprolactinemic patients. Also, its appearance is neither correlated with prolactin levels or with the presence of tumor. Approximately 5% of patients present with visual field defects. There are many causes of a mildly elevated serum prolactin concentration, including stress and recent physical or breast examination. Other causes include hypothyroidism, polycystic ovarian syndrome, and several drugs, like dopaminergic antagonist phenothiazines, domperidone, and metoclopramide. Hypothyroidism. In approximately 5% of patients with hyperprolactinemia and galactorrhea, the underlying etiology is hypothyroidism. Both hypo and hyperthyroid states may produce secondary amenorrhea and anovulation. Serum TSH is raised, while T3 and T4 value are lowered in hypothyroid state. In subclinical hypothyroid state, while serum TSH is elevated but T4 is normal. Serum prolactin may be raised even beyond 20 nanogram per milliliter in hypothyroid state. This is due to increased sensitivity of prolactin secreting cell of anterior pituitary to thiotrope hormone. A low serum thyroxine level eliminates negative feedback signaling to the hypothalamic pituitary axis. As a result, thiotrope hormone levels increase. Positive feedback signaling that stimulates dopamine secretion is also absent, causing a decrease in dopamine levels. Elevated thiotrope hormone stimulates release of prolactin from the pituitary gland. The reduced dopamine secretion results in elevated levels of TSH and prolactin. Now, ovarian causes of amenorrhea. It's a resistant ovary syndrome and premature ovarian insufficiency. Resistant ovary syndrome is cause of ovarian failure that can lead to secondary amenorrhea. Resistant ovaries result from a functional disturbance of the gonadotropin receptors in the ovarian follicles. In resistant ovarian syndrome, follicles are present. FSH receptor is either absent or defective. It may be a cause of primary or secondary amenorrhea and is resistant to exogenous gonadotropin stimulation. Diagnosis of this condition requires that the patient has a normal 46XX karyotype, normal secondary sexual characteristics, elevated plasma FSH and LH in the menopausal range. Multiply follicles are seen on ovarian biopsy. Premature ovarian insufficiency. Ovarian insufficiency, by definition, is the cessation of periods accompanied by raised gonadotropin level prior to the age of 40 years. It may occur at any age. The exact incidence of this condition is unknown, as many cases go unrecognized, but estimates vary between 1 and 5% of the female population. Women with ovarian failure experience the symptoms and signs of estrogen deficiency. On this slide, you see different causes of premature ovarian insufficiency, but most of them are idiopathic. Asherman syndrome is a condition in which intrauterine adhesions prevent normal growth of the endometrium. The adhesions breach the anterior and posterior walls of the uterine cavity and are usually avascular. Also may contain vessels, muscle, and even endometrium. This may be the result of too vigorous endometrial curettage affecting the basalis layer of the endometrium, or adhesions may follow an episode of endometritis. Scarring of the uterine cavity is the most frequent anatomic cause of secondary amenorrhea. On this image, you may see the adhesions breach the anterior and posterior wall of the uterine cavity. Mild scarring can be corrected by surgical lysis. Severe cases are often refractory to therapy. In some cases, a balloon or intrauterine device may be placed in the uterine cavity to help keep the uterine walls apart during healing. For the correct treatment of amenorrhea, the first step is to establish a cause for the amenorrhea. Diagnosis of amenorrhea includes history examination, general physical examination, and laboratory studies. Now let's talk about uterine bleeding. On this image, you see the causes of uterine bleeding. It may be pregnancy, injury of the cervix, and injury of the uterus. On this slide, you see abnormal uterine bleeding new classification system known by the acronym PALM-COIN, which was introduced by the International Federation of Gynecology and Obstetrics, FIGO, and is supported by the American College of Obstetrics and Gynecology. In terms of etiology of abnormal uterine bleeding, the system used PALM to represent the structural causes of abnormal uterine bleeding, including polyps, adenomyosis, leiomyoma, malignancy, and hyperplasia. COIN delineates the non-structural causes of abnormal uterine bleeding, including coagulopathy, ovulatory dysfunction, endometrial and iatrogenic causes, and those etiologies that are not yet classified. Endometrial hyperplasia is a disordered proliferation of endometrial glands. It results from estrogenic stimulation of the endometrial tissue with a relative deficiency of the counterbalancing effects of progesterone. Endometrial hyperplasia is the result of chronic exposure of estrogen along with a relative deficiency of progesterone. Typically, causes of endometrial hyperplasia is an corpus luteum insufficiency, polycystic ovary syndrome, obesity with metabolic syndrome, inappropriate hormone therapy, tumor. On this image, on the left side you see endometrial hyperplasia, and on the right side normal endometrium. It proposed two categories based upon the presence of cytological atypia. It's an hyperplasia without atypia, an atypical hyperplasia, or endometrioid intraepithelial neoplasia. The endometrial hyperplasia, diagnosed by hysteroscopy, transvaginal ultrasound, laboratory test, endometrial biopsy, and dilatation and curettage. Intermenstrual bleeding is characterized by bleeding that occurs between regular menstrual periods. Primary causes include cervical lesions, endometrial polyps, carcinoma, fibroids, and adenomyosis. Now, let's discuss dysmenorrhea. Dysmenorrhea is defined as painful menstruation that prevents a woman from performing normal activities. The pain in the lower abdomen just before or during the menses not the only symptoms of dysmenorrhea. It may also be accompanied by other symptoms, including diarrhea, nausea, vomiting, and headache. Dysmenorrhea may be caused by clinically identifiable causes. It's a secondary dysmenorrhea, or by an excess of prostaglandins leading to painful uterine muscle activity, which is primary dysmenorrhea. Primary and secondary dysmenorrhea are source of recurrent disability for a significant number of women in their early reproductive years. The incidence of primary dysmenorrhea is greatest in women in their late teens to early 20s. Secondary dysmenorrhea becomes more common as woman ages because it accompanies the rising prevalence of causal factors. Primary dysmenorrhea is caused by excess prostaglandin F2 produced in the endometrium. Prostaglandin production in the uterus normally increases under the influence of progesterone, reaching a peak or soon after the start of menstruation. Prostaglandins are potent smooth muscle stimulants that cause intense uterine contraction. Secondary dysmenorrhea is caused by structural abnormalities or disease processes that occur outside the uterus, within the uteral wall, or within the uteral cavity. Common causes of secondary dysmenorrhea include endometriosis, adenomyosis, pelvis inflammatory disease, adhesion process, and leiomyoma. On this slide, you see symptoms of primary dysmenorrhea and their estimated incidence. The pain in dysmenorrhea are usually radiate to the back and down, starts at onset of menstruation and lasts hours to days. And now we are talking about premenstrual syndrome. Premenstrual syndrome is a group of physical, mood-related, and behavioral changes that occur in a regular cyclic relationship to the luteal phase of the menstrual cycle, and that interfere with some aspects of the patient's life. The exact etiology of premenstrual syndrome is unknown. A woman is considered to have premenstrual syndrome if she complains of recurrent physiological or somatic symptoms occurring specifically during the luteal phase of the menstrual cycle and which resolve in the follicular phase at least by the end of menstruation. Past hypotheses have included abnormalities in estrogen and progesterone balance, also disturbance in the renin-angiotensin and aldosterone pathway. However, studies have suggested that also women with premenstrual syndrome have normal levels of estrogen and progesterone. They may have an abnormal response to normal hormonal changes. A wide range of symptoms has been described, but it is their timing and severity are most important. Symptomatology must occur in the second half of 3 consecutive menstrual cycles, and there must be a symptom-free interval of at least 7 days in the first half of the cycle. We usually divide premenstrual syndrome clinically to mild case and severe case. In mild case, 3 or 4 symptoms appear from 2 till 10 days before menstruation. In severe case, from 5 to 12 symptoms appear from 2 till 14 days prior menstruation. The most useful diagnostic tool for premenstrual syndrome is patient symptom diary. As the etiology is multifactorial, various drugs are used with varying degree of success in premenstrual syndrome. Thank you for your attention.